Have you been stressed, anxious, or worried? Have you felt pangs of loneliness in recent times? Are you longing for greater connection with others in the world around you? In a phrase, are you looking for happiness? You are not alone. Millions of others are seeking this feeling of spiritual, mental, and physical wellness too. This podcast explores the underlying causes of unhappiness and shares with us the secrets of rewriting the frequent thoughts and redirecting the common behaviors that keep us in that state. Join forensic psychologist and best-selling author Dr. Neehall and her guests as they dive deep in the realm of psychological wellness and explore ways of finding happiness on demand.
Dr. Sandra Belfry is a licensed clinical neuropsychologist and clinical psychologist practicing in Ontario. In clinical work, Dr. Belfry diagnoses neurodegenerative conditions, brain injury, and mental health disorders in adults and seniors. She provides psychological treatment and cognitive rehabilitation interventions. Her new innovative women's brain health education program, Menolink, Connecting the Dots, was created to address the gaps in women's knowledge regarding health risks related to the interconnectedness of reproductive, mental, cognitive, and physical health issues across our lifespan. In addition to being the founder of Menolink, Dr. Sandra Belfry is the Director of Clinical Services for the Healthy Aging and Dementia Clinic and the Women's Menopause and Brain Health Clinic at Lifespan Psychological and Neuropsychological Services. She advocates for seniors and women's rights in accessing healthcare. So without further ado, I'd like to welcome Dr. Belfry. By the way, Dr. Belfry or Sandra wears multiple hats, just like most of us women do. But I need to tell you that one of the things that she's doing that's really exciting is through Menolink, the work she's been doing there. And so I'd like to ask you the first question. What are some of the physical symptoms that occur not just during menopause, but prior in perimenopause?
Over the years of my career, my work in sexual health and dementia health was always separate at different places, different types of healthcare settings. And when I went into private practice about 15 years ago, I started a dementia clinic. And then I noticed sort of at the time that COVID started, and after that time, my referrals for women were getting younger and younger. And I saw that there was this real convergence between sexual health, in particular reproductive health transitions, and dementia questions coming from physicians and neurology in the community, as well as the patients themselves. And also for myself, I was going through perimenopause at the time and also started to make those connections personally. And so it was kind of like the planets aligning in a way. Everything added up to this convergence of reproductive health or sexual health, hormone health issues in women, and then dementia assessment, dementia diagnosis, and how we can make and mood diagnosis and treatment, how we can make all these things better and more accessible for women and older adults.
So speaking of the mood connection, can you talk to us about menopause and mood connection?
It's actually a very long answer, so I'll just kind of abbreviate. I mean, there's a lot of impacts to mood and anxiety symptoms that can happen at the perimenopause transition into postmenopause. And that's because...
just to interrupt from these far years, because I know you do a brilliant job of this. Can you help us to understand when maybe perimenopause starts? Because a lot of physicians don't know.
And so usually I start out with this information even when I'm training clinicians or giving lectures for the public. And so perimenopause is a long process. It can be up to 10 years, in fact. And so it's the early transitions of the reproductive health transition where we move from being able to reproduce to not, obviously, which is going into full menopause. And so in that initial phase of perimenopause. It's actually divided into early and late stages. And so in the earlier stages, we'll see that there's some new symptoms so a woman might experience, from an emotional perspective, some reactivity, irritability, sort of mood lability fluctuation, and then minor changes in their actual cycle length. And so that is, usually the average cycle length is about 30 days. And so that could expand by, about up to maybe 10 days more, so a longer cycle length. Mm-hmm. And then that's the early perimenopause. And then in later postmenopause, there's greater, more like a 60-day cycle length, meaning you're missing periods up to a couple months difference between them. Specifically, also the amount of bleeding can increase or decrease. The length of your actual period can increase or decrease. And so there's just changes in your actual period, but it's the cycle length, which is the 30 days of going through each phase of the menstrual cycle, that does expand over time. And so that is how physicians will help determine whether you're in early or late perimenopause.
Hmm. And what about happiness and identity and role transitions? It's very broad.
Yes, very broad. And
you use IPT, right? But maybe
I use CBT, IPT, ACT, sometimes art therapy, a whole number of different strategies, but CBT is the main researched evidence-based psychotherapy recommended for menopause coping or perimenopause coping. But IPT does apply really nicely. And so one of the things that I've noticed happens in any reproductive transition, whether it's pregnancy, postpartum, menopause, or menarche, which is your first menstrual period, is that we also, in addition to having physical symptoms, perhaps mood or cognitive symptoms that accompany that, there's also usually some changes in sense of self. And so that's really, how we define ourselves, our identity, and our roles in life. So I use IPT to address that as a shorter answer, because IPT focuses on role transitions such as that. And so we use that to reflect on, old roles and new roles, as well as for enhancing communication between people in order to improve mood.
And what do you do when you have a client coming to see you and saying, I feel overwhelmed, I can't sleep well, it's interrupted, I don't feel like myself anymore?
Mm-hmm. It's a really big question. First, we start off with going through all the symptoms and making sure that, everything is being addressed from a physical perspective, mental health, cognitive health, and reproductive health perspective. And so sometimes that requires a letter to a physician or helping a woman advocate for herself, for her physical symptoms, and getting the right treatments and finding a certified menopause practitioner to do so. So I help women with that piece. But then from the mood perspective, I might provide a diagnosis of a mood disorder that could have developed during the perimenopause transition. Also look at her history, such as having a premenstrual dysphoric disorder, which often goes underdiagnosed or unnoticed. And so helping clarify diagnoses in order to improve treatment. And then also looking at insomnia diagnoses as well, and if they're contributing to the overall mood and cognitive problems that are being reported. And so then I offer CBT or IPT treatment. I do a CBTI treatment for sleep specifically as well with people. And then I do some cognitive compensatory strategy training and application work with women to help with brain fog, say in the workplace or at home.
Can you explain brain fog to us in more detail? Because I know a lot of people don't quite grasp it.
Yeah, and I think it's one reason for that is there's no clinical definition of brain fog that's been accepted for menopause brain fog. There's been other brain fogs that have addressed this issue, like concussion-related brain fog or autoimmune related condition brain fog. But for, in general, there is a bit of a lack of agreement on the definitions, which doesn't help the people who are experiencing brain fog. So right now, the literature points to several changes in cognition that are temporary for women. So these can be most typically verbal memory changes, particularly difficulty with remembering people's names or, events that were just discussed in a conversation. Other things that are a part of that brain fog are like feeling, fogginess or difficulty thinking. So difficulties with working memory, holding things in mind, as well as some changes to executive function, like problem solving. So being a bit less efficient and having difficulty managing tasks. Women used to be able to, say, manage at a better level prior to, say, the onset of brain fog. And brain fog can fluctuate. The other piece that comes into play is a slowed processing speed. And they've found this happens in women throughout the menopause transition. And so all of the changes that have been identified, the cognitive changes, are not impairments, but they are changes that do impact women, and some more than others. And so women who might struggle more with brain fog tend to have other conditions, pre-existing conditions like ADHD or premenstrual dysphoric disorder, or they might have an autoimmune condition that also causes inflammation and brain fog, or an additional brain injury like a concussion. And so when those things happen, brain fog can be worse. But one of the biggest contributions to brain fog that's been identified in the literature is actually poor sleep and a high level of hot flashes or night sweats, which are called VMS symptoms, vasomotor symptoms. Yeah.
Yeah, that's what a lot of my clients talk about. The other problem is a reduction in feelings of high self-esteem, questioning their worth, questioning if they perform at work.
Yeah, and those feelings are really common during the menopause transition, because when you have experienced a cognitive inefficiency that you never experienced before, and you start making mistakes or not seeing your mistakes and they're pointed out to you, it can really impact your self-esteem or your confidence in certain abilities. As well, if you're experiencing mood changes, that can also drive your self-esteem down. And so it can be a pretty confusing time with all of the new symptoms that can happen. And a lot of these symptoms are typical for a lot of women because the brain changes that happen and the reductions in estradiol in the brain actually create changes in our serotonin and dopamine levels. And because those things help regulate our mood, and to a lesser extent, some cognition and temperature regulation, that's why we see these changes. And it takes a while to get through the full perimenopause transition and into postmenopause before those things start improving again.
A little variable that you threw out was interrupted sleep. And that,
right.
I mean, it's like a layer cake. You put that onto self-esteem, onto moodiness, irritability, and hey, what's going on? You used to be such a calm, composed woman. Now you're flying off the handle just like that.
Yes. Yeah. And sleep's so important for our mood regulation. And that's a really, really important point. And so the other piece is during the perimenopause transition, your estrogen and progesterone are decreasing, but they're also fluctuating dramatically. So they can drop and spike, which also creates differences in the way your brain regulates its neurochemicals, neurotransmitters. And so it's just your brain has to adopt to this new way where this kind of spiking or dropping happened in a 30-day cyclical pattern when you go through perimenopause, because your cycle then gets disrupted. It's no longer a 30-day pattern. It can be spiking and dropping in a 10-day pattern or a 40-day pattern. And your brain has a hard time anticipating that and managing that. And so, that's how we end up with a 10-year adaptation process.
Yes, and it's a very difficult process, I have found, for a lot of my clients.
Mm-hmm.
Just in general, I don't think we've got sufficient education out there to tell people what it's all about.
Yes, yeah, and that's why I created MenoLink. Connecting the dots was, I provide therapy and assessments in my clinical practice, but I noticed there was just this huge information gap. And part of the reason for creating the workshops that I created in MenoLink is to help younger women, actually women of all ages, learn about women's brain health and the changes that happen in a reproductive health transition throughout their lives. And so being ready for, the changes that can happen in pregnancy and postpartum, as well as later in menopause. And so my workshops are intended for sort of 18 to 100, and they're intergenerational, so that women can attend with their mom or their sister, their aunt, their grandmother, also to kind of, bring about the importance of family conversations about hereditary issues, and also to empower women to discuss their reproductive histories. So, there's lots of wonderful birth stories, but also some really nice menopause stories. And then there's challenges that, our adult daughters might need to know. But there's also things that women need to know at every age group in order to have or optimize their brain health. And that starts at a young age. For example, having a higher education is one of the most protective factors we can have for our brain health. So we should be focusing on that in our youth. Also, socialization skills is something that helps prevent dementia when we're older. And so we develop those skills when we're younger. And it's important to teach people about the importance of that, as well as how to manage a mood symptoms or a mood disorder, how important it is to get treatment at younger stages and early, because dementia can be linked to depression can be linked to developing dementia in older age. And so anything that women could learn about, I kind of include in my workshops across the lifespan. So it's meant for women to understand all the different challenges at different times, but also the protective things they can do at each age span to help their brain health.
I think that's really important, because the earlier we start, I think, is the better. But in our culture, that's not something we generally talk about, do we?
Not really. And so it when sort of the menopause movement started, there was a lot of discussion about, middle age is the time when you need to make sure you're making the right lifestyle choices, like exercise and eating. But those types of habits actually start off when you're much younger. So, you set those goals and lifestyle habits actually when you're in your 20s. So it's good for people in those age groups, those younger age groups, to know that there's things they're doing to promote their brain health as they age. And we can start these things at any age to have a benefit for our brain health, but the younger we start, the better. And, the more aware we are of the different ways to protect our brain health, the better women can do. During this time where we're in a really reduced research in women's health kind of quandary in the world, where we actually haven't researched every specific aspect of menopause and brain health and aging. And so while the research catches up to what women are now reporting and experiencing, we need to make sure that, women are, as educated as possible so they can advocate for themselves. And one of the things I like to focus on as a part of my workshops is actually how to talk to your doctor, how to convey symptoms in a cohesive manner, in a way that makes sense for doctors, so that you get the treatments, the diagnoses that you need.
I think that last bit is crucial, how you speak to your physician, because I think we need to teach physicians as well about what menopause and perimenopause really means.
That's right. Yeah. And so the way I write my reports, I've actually changed that since I retrained myself, and I include a whole reproductive health section. And so it's not just about perimenopause. It could be about, premenstrual dysphoric disorder and identifying that and how it's done. And so my reports right now are very long and lengthy in order to help educate anyone who's actually reading it, including physicians. I see all kinds of comments from my patients' reports. So when I do a cognitive assessment, I'll read their neurologist report, psychiatry, family physicians, and I'm able to see, the points that we've all missed, even other psychologists, the points we've all missed in our assessment skills. And that's because we were never taught to view women's health with a reproductive lens. And I think this will be important for changing things for the future. And so the way that I developed MenoLink was actually based on this lens, where we're focusing not just on mental health, cognitive health, and physical health, but also how reproductive health factors tie in to our overall health and brain health over the lifespan.
I think that's really important. And the impact, I guess, in the workplace, for instance, the impact must be huge.
Yeah, there's a substantial amount of women who actually stop working during the menopause transition and give up their career due to frustration over symptoms, inability to cope with symptoms. And so one of the reasons why I started MenoLink as well is to provide a virtual, more accessible treatment hub to address mental health, sleep health, and cognitive health. And also to be able to impact more women positively. I'm doing that by offering treatment groups. So I'm offering a sleep management support group and a goal management training support group, which is to help with brain fog. It's an adapted goal management training, which is a program developed by Baycrest. But I take the pieces that are relevant to menopause brain fog and apply them, as well as other cognitive compensatory strategies. And so, the hope is that more women can access the appropriate treatments and help in order to keep them working. A lot of women I see in my menopause clinic are off of work. And so I will do their treatment and return to work plan and their accommodation plan, which I do that in a very specific way to help manage fatigue. So we're building stamina to address fatigue and brain fog once the mood symptoms have gone into non-clinical ranges and they're ready to get back to work, because the brain fog piece can still persist even when the mood symptoms are treated.
How long do you reckon the brain fog might last?
Well, I think it's highly individualized, and it depends on pre-existing conditions for sure. But what the research points to is it can happen anytime during perimenopause and tends to kind of last into the early phase of postmenopause. early postmenopause is the first 6 years following your last menstrual period. And so menopause is actually just a day in time. Menopause is when you've gone 12 months without a period, or you've had a medical procedure that stopped your ability to have your period. And so that early postmenopause phase in the first 6 years, there can be still some brain fog, but the research hasn't really focused as much on that piece. So I don't have a definitive answer, just that some studies have said, yes, some people have some brain fog kind of into the first two years post-menopause. But I've seen women anecdotally on a case-by-case basis where that's lasted a little longer than that.
But yet you're giving us a ray of hope, that there is hope.
Yes. And yeah. So there has been research, and it's low case number studies right now, but it is MRI research being completed by Dr. Lisa Monscani that is showing how the women's brain actually adapts to the menopause transition. And so that's why this long period of time going through perimenopause to postmenopause and these extended symptoms. But essentially, if I were to sum it up quickly, what she's finding is that we have estrogen receptors in our brain, and as estrogen reduces during perimenopause and gets to its lowest point in postmenopause, the brain actually adapts by developing an increased number of receptors so that it can get at as much estrogen as possible. So it's kind of, you liken to what we were told about adolescent and the brain. It's a time for the brain to revamp itself and become more efficient. We know that teenagers are very tired during this process. We're kind of likening it to a similar process in menopause, where the brain is changing and adapting and progressing.
Yeah. Now tell me, I know we're running out of time. Can you give us some practical takeaways for our listeners? Some things that they can do or?
Yeah, I think one of the most practical things is to track your symptoms. There's lots of great symptom trackers out there, but the Canadian Menopause Foundation has a really good tracker on their website. And then there's also some excellent apps out there, but track your menopause symptoms, and so that you can better talk to your doctor about your symptoms, and then your doctor can refer you to the right place, whether you need a psychologist or perhaps you need to see a certified menopause practitioner if you've got some symptoms that need to be addressed that are outside of your physician's scope, and so on. And so it's really about being aware of your own symptoms, and then also educate yourself. People can attend one of my workshops to learn more about the menopause process. People can find other resources of information. There's lots of doctors doing talks out in the community these days. And so there are a lot of opportunities. It's just, not believing everything you read on the internet and that you see on Instagram is maybe a really good takeaway, because there's a lot of misleading information on those types of forums.
So based on your extensive clinical experience, what's actually clinically freeing about menopause?
Well, one of the things that I do see, because I see a lot of older and postmenopausal women, is that when you get into that postmenopause phase, which we're in for almost half our life, women start to, there's some expletives used for the phrase, but they care less about what others think. And they're more interested in doing things that they themselves enjoy or find meaning in. And this is a big change for women, because we're often live our lives to be connected and do things for others or think of others, whether it's children, parents, spouses, and that sort of thing. And we live in this very interconnected way, but the menopause transition is a bit freeing in that it kind of gives us permission to do more things for ourselves and more self-care.
That's really a profound statement. It's true. Now, where can our listeners get a hold of you? Can you tell us some links or things that they can
Sure. Yeah. So Menolink, connecting the dots, I have a website, and it's www.menolink.ca. But I can also be found doing in-person clinical work at Lifespan Psychological and Neuropsychological Services in Burlington, Ontario. And if somebody wants to email me, it's drbelfry@menolink.ca.
That's wonderful. Thank you so much. I mean, I've learned a lot from you, and I think that what you've just shared with our listeners is brilliant. So thank you.
Great. Thanks for having me.
Thank you for joining this discussion on happiness. We hope this helps to inspire you to lead a more joyful life. To dive deeper into the subject of happiness, be sure to check out Dr. Neehall's book, Happy is the New Healthy, available as an ebook or hardcover. For additional resources, visit our website at drneehall.com. Until next time, stay happy.